I am Debbie Brooks, Senior Product Marketing Manager at ChiroTouch. Welcome to today's webinar. We have our special guest, Dr. Colleen Auchenbach, who is Director of Education at KMC University. Today, she'll be covering how to accurately code and document patients' routine office visits. Her journey into the chiropractic profession began within her own family, inspired by her father's practice. After graduating cum laude from Cleveland Chiropractic College, Dr. Colleen set out on a fulfilling career spanning over 20 years by serving patients in a bustling family practice. Along the way, she honed her expertise, earning certifications such as peer review, medical compliance specialist physician from Logan University College. She followed that by becoming a certified professional medical auditor in 2022 through the American Association of Professional Coders. She transitioned to a role at KMC University in 2020 as a documentation specialist. Dr. Colleen brings a wealth of firsthand experience from her time as an associate doctor in a large practice. Her mission is clear: to empower chiropractors with the essential knowledge of documentation, coding, billing, and compliance, enabling them to mitigate risk and focus on delivering exceptional care to their patients. Without further ado, let's get started. On to you, Dr. Colleen.
Thank you, Debbie. That is a lot of letters and information. So my specialty obviously is chiropractic. I specialize in documentation. We're going to go heavy on documentation today versus the coding. There's a little bit of coding in here, but not a lot. Really wanting to just dive into documentation from a routine office visit perspective. So as Debbie said, I am with KMC University, and I am loving it. I get to work with chiropractors all the time on documentation, coding, and compliance. And so we'll talk about mostly documentation, like I said today, a little bit of coding, a little bit of compliance. The first thing that we want to really establish as we're diving into this topic about routine office visits is the difference between and what we mean when we say a routine office visit versus an initial visit. So when a patient is coming in either as a new patient or as an established patient with a new episode of care, we're going to have an initial visit. And that initial visit is different, looks different, is documented differently than our routine office visit. We've got a little bit of a different format for the initial visit. We're doing an evaluation and management service, for example, versus our routine office visit, which has a different format and really is the tracking of the patient progress through the treatment plan that you established for them on that initial visit. So initial visit, foundational visit to establish medical necessity and create our treatment plan, and then routine office visits, essentially tracking that treatment that you've recommended and tracking how the patient's progressing. When we look at Medicare's documentation guidelines, we can see that they split them up into these two different types of visits. So again, that initial visit, which is what Medicare also refers that to, has the format of a history, an exam, an assessment, a diagnosis, and a treatment plan. And you'll see those headings in an initial visit note. Different from what Medicare calls a subsequent visit, or what we call a routine office visit or a daily visit, which would be more along the lines of a SOAP format, but is still going to hit those same similar ideas of a history with our complaints, an exam with our part findings, an assessment with progress, and then the daily treatment. So really, similar things being documented, but there is a separation between the two different types of visit and the intent of that visit. As we look at a cycle of an episode of care, which is what this is showing us, you can see that the first half of this cycle is our initial visit. We're taking a history. We're establishing our patient's functional capability and establishing their functional deficits We're examining them, arriving at a diagnosis, and creating a treatment plan. The second half of this cycle then is going to be our applying that treatment plan to the patient, where we're doing our daily notes, we're doing any reevaluations that we've decided need to happen, and then on to the end of the full episode, which would be discharging the patient from active care, from the episode of care on to maintenance care or wellness care. What we're really going to focus on today is that functional daily note piece. So what Medicare and almost every other payer really wants to see is that we are providing medical necessity in our notes, that we have some kind of a framework of a plan of how we're going to take care of this patient, that we have a start date and an end date, that we're matching our diagnosis with the complaints, with what we've documented in the exam, that matches with what we're coding and what we're billing, and then that the patient is actually following that plan and how they're doing with what treatments we're giving them. If you are doing modalities or active therapies, this is where we even want to start talking as soon as the history about establishing support for the need for those modalities and therapies. So learning what we need to know about the patient in the history, then examining them for findings that then will reflect the diagnosis, and all of that together, piecing together to support rationale for those different therapies. So really, thinking through this whole cycle of an episode is important, even from the beginning. Our format for our note for a routine office visit, or a subsequent visit as Medicare calls it, is the SOAP format of subjective, objective, assessment, and plan. And that subjective piece is where we're putting in the patient's complaints from their perspective. The objective piece is where we're putting in what we have learned about the patient as far as findings are concerned from our exam. The assessment piece is where we're establishing what the condition is and what the progress of the patient is. And then the plan is where we're saying what we're actually doing with the patient. And what we want to really look at here is how our SOAP format of our note and our exam expectation from Medicare of part fit together. It's a really great pairing of a note format and a requirement from Medicare to support the subluxations that we're going to want to treat. So SOAP, again, is the documentation format for our daily encounters. PART is the required documentation to support our subluxation segmental joint dysfunction. And although it is a required part of the note, it's not enough. It's one piece. And so let's kind of look at how this fits in to SOAP. Our S can be seen similar to our P of part. So our S of SOAP and our P of part can be similar. Our P is our pain or tenderness. And if the patient is telling us that they're hurting, that when I do this, it hurts, that, I can't do this or it hurts, these are the things that we can record in the subjective section. When we are examining the patient and we find pain, that would belong then in the objective section. But don't negate that the pain can happen in our documentation in the subjective portion of the note. The patient hurts in their low back, for example. Functional questionnaires can be part of that as well. If there's any indication of pain, our pain scales, our VAS scores from the patient, these are all pieces that can be used to document that P of part in our subjective section of the note. Now, the objective section of the note is going to be more, likened to the ART of part. Again, we could still have a P in there as well, but the ART is, and we'll break this down in just a minute, but we've got our asymmetry, our range of motion, and our tissue tone changes. Our exam of the patient, when we do that and have our findings from our clinical exam of the patient, we want to make sure that we're quantifying what they're telling us subjectively. And our daily physical exam is going to be a little bit different than our initial exam. Typically on an initial exam, we're going to have a lot more of an exam going on with our orthos and our neuros and full range of motion testing. Daily physical exam is going to be more like our chiropractic findings of how the patient's doing on that day. We want to use this ART to gather data for the treatment so that we're identifying the segments that we want to treat. And then when we take the S of SOAP and the P of part, and we add it to the O of SOAP and the ART of part, those two things together then will lead us into our assessment section of the note. And that's where we're going to capture how the patient's responding to treatment. Why do they need more care? Are they meeting their goals? And that's going to be from the doctor's perspective of patient progress through the episode. And we're going to talk about a little bit more specifically how to do that when we get to that section. But just kind of as a comment towards that, whenever we just say better or worse or same without any other relevant information, that's just not enough anymore to show our patient progress. So we'll dig into that and show some examples here in a little bit. So coming back to ART of part and remembering that our Medicare requirement for showing a subluxation using part as the physical exam requires that we have 2 of the 4 findings. One of them has to be A or R. And the reason that is because this is where we identify where the subluxation actually is. So there are many things that we can use as findings for A. We can have observable asymmetry, either posture or local asymmetry with static palpation. We can talk about gait abnormalities. We can talk about leg length discrepancies. There's lots of ways to show asymmetry or misalignment in our notes based on our findings of what we see with the patient. R is the other place where we can show those specific subluxations or segmental dysfunctions, and just really kind of depending on how you identify those, whether you're using A or R or possibly both. But R is the range of motion abnormality, and that can be through active range of motion, passive range of motion, segmental range of motion, regional range of motion. You can say, restrictions in the actual segment joint or our range of motion measurements. So this is where you could potentially also use an instrument to measure actual degrees. Not usually something that we do on a daily visit, more an initial on that one, and then daily just talking more generally about mildly restricted, moderately restricted, severely restricted, that kind of language whenever we're talking about range of motion, or just doing the segmental restriction on the actual spinal listing. Our T of part is our tissue tone changes. There can be multiple tissue tone changes that we're seeing and documenting. We can observe things as the patient's walking in, as they're standing in front of us, as they're laying on the table. We can find through palpation many tissue tone changes. And this is where we really want to make sure that we're gathering our soft tissue findings. So if we are going to recommend modalities, and it's appropriate to use a passive modality or an active modality, and our rationale for those modalities are going to be based on muscle spasm, inflammation, restrictions in range of motion. In our notes, we have to tie those pieces all together to make sure that we have findings that say those things. If our reasoning for why we're going to do something is that we have muscle spasms, then we need to make sure that we're documenting where that patient's muscle spasms are located. The other thing is any place that you can grade your findings, especially your soft tissue findings, where then we can move into visit to visit, being able to document changes in those findings. That is a really important thing to start doing if you're not doing it already. The reason being is because a lot of our payers are wanting to see patient progress from a functional point of view and from an objective finding point of view. And when we can take the time to grade our findings from the beginning, it's easier to show progress with the patient from an objective finding point of view as we move through the episode of care. For assessment of our subsequent visit or our routine office visit, and again, this is the assessment from SOAP. So subjective, objective assessment. The documentation, this is where we show our doctor thinking. How's the patient progressing? How do we know that? What are the changes since the last visit? Rather than saying the patient's better, we would say the patient's better because they're reporting they're able to walk further without pain and there are less restrictions in their lumbar spine, for example. So that extra detail of why you're thinking they're better from a functional perspective and an objective finding perspective is very important. And this is a place where we have seen payers deny because there is no evidence of patient progress in the documentation. So super important to, be open to adding to your note in the assessment section of your routine office visit so that we can document patient progress through the entire episode. We want to make sure that we're painting that picture towards our goals. So initially, we're going to have our treatment plan. In our treatment plan, we're going to have functional goals. In our routine office visits, then we're going to paint the picture of the patient's progress to those goals. Now, one thing to kind of bring up here is that your patient's progress could be stagnant. That's very possible and very realistic. It happens, right? We still want to try to quantitatively document progress in any way that we can, even if the patient's coming in and saying, I'm the same. If we're seeing anything from a, clinical perspective that's different, we want to document that as well. So keeping the measurements and the numbers on our objective findings and always talking about function helps to paint that picture, even if the patient is not making, drastic progress visit to visit for a week, right? We can still show progress, and that will keep us meeting Medicare's guidelines of showing medical necessity or functional changes visit to visit. In our P section of our SOAP, then is where we're going to document what we did. S of SOAP, P of part, plus O of SOAP, ART of part leads us to our assessment of how the patient's progressing. And then that then all supports and points towards our plan or what we did to the patient that day. If there's any changes in the plan, then we'll talk about where we need to document that here in a little bit. On our subsequent visit or our daily visit, our routine office visit, in the plan section, these are the things that we want to make sure that we're documenting. We want to document the technique we're using, the specific segments that are being adjusted. We want to separate out our primary medically necessary segments from our compensatory segments so that we're coding correctly, and we'll show some examples of that. We want to talk about how the patient responded to care, and then we want to make sure that if our passive and active therapies are happening on that day, that we're documenting actually what was done. What are the details of the therapy that's happening? what are the settings, what areas being treated, and then how the patient's responding, as well as time if it's a timed code. Okay, so again, we're building off of our initial office visit with our history, exam, assessment, diagnosis, and treatment plan, and we're documenting our executed treatment. So let's just go into the different sections of the note a little bit more detailed here. And we're going to start with subjective. Subjective, think about subjective as the functional update of the patient. They're coming in and they're telling you how they're doing functionally. So subjective is absolutely going to include complaints that the patient is presenting for and that we're treating them for as part of our treatment plan. But we also want to say, how are you doing since your last visit with fill in the blank function based on the goals that we set for our patient. So knowing what those functional deficits are from our initial visit lets us have that conversation with the patient as they're coming in. How is your sleeping, Mrs. Jones? Our goal is to have her sleep better without pain. We're going to ask her when she's coming in, not just tell me what your pain level is, but how is your sleeping? Tell me how that's going, and then document that in the subjective section. This really helps lead the conversation as the patient's coming in to keep it towards that functional progress. We've got to include the patient's, reporting of that. For example, they're better because they're able to brush their hair without so much tingling in their thumb and index finger. They're worse because they were unable to put on their socks. They're the same, and then add the extra detail of because they were not able to walk further without pain. Just adding that extra functional detail really makes a difference in hitting the mark of showing patient progress. One place that we can lean on our team members to help us out with is this subjective section of the note. So team members can, welcome the patient in, ask them these questions so that we have that subjective information gathered. That will lead the conversation to have the patient be focused on and talking about their functional progress, and then hand over to the doctor at that point. This can save a lot of time. And one thing that we have put together is just kind of a little bit of a decision-making matrix for your team members, where if a patient's coming in, being able for them to assess, is this active treatment? Is this maintenance treatment? Maybe it was maintenance treatment, but we need to start a new episode, kind of going through some of the questions. So if you kind of just look at this flow chart, and I'm not going to go through every line, but right across the top, is the patient in active treatment? No. Are there active symptoms? No. Are there current functional deficits or restrictions? No. Okay, this is a wellness preventative maintenance visit. So we're going to document to the level of wellness preventative maintenance. And I'll show you a few examples of those as we go through these sections. Versus, is this patient in active treatment plan? Yes. Then we're going to start with documenting the visit number of how many visits from our plan, such as 3 out of 10. And then we're going to go into, are there any changes in complaints? What is your functional change since the last visit? And documenting that for the patient so that we're continuing to support medical necessity right from the start of that note. For our subjective, don't forget that we need to have information for each area of complaint. So rather than squishing all areas of complaint into one notation and then trying to have a pain scale and trying to have a functional comment, it's really important that you focus on each area that makes sense from what you gathered from the patient on that initial visit. So maybe we've got an upper body complaint and a lower body complaint. We want to have two separate notations of that so that we can gather the accurate information to transition to the objective section. And then again, documenting changes since the last visit, really capturing this daily encounter on each visit of what's going on with the patient and then with their treatment. Okay, so here is some examples of a note in ChiroTouch. This is the subjective section of an active treatment note. So we're going to start with active treatment. You can see here that we've got 2 complaints. We've got a neck complaint, we've got a low back complaint. We're saying that this is acute active care. That is super important for Medicare that we establish that for sure. We're also saying this is visit 5 of 20 visits. So we've got an initial visit treatment plan that's got 20 visits in it. We're on visit 5. That also tells Medicare where we are at in our treatment plan. And they definitely want to see that. So you can see as we are documenting this complaint that we're saying things like the complaint has improved. And then we're adding the patient reported I was able to sleep longer. That's that functional piece that we're talking about. We also have the functional deficit listed as sleeping is still difficult but has improved slightly. Same thing with the low back. We've got our, dull, achy, discomfort where it's at. We've got a 3 out of 10 pain scale, but then additionally, we've got that sitting has improved and she can sit comfortably in a chair for up to 20 minutes without pain. That functional piece, super important for active care when we're billing any third-party payer. This would be what a preventative maintenance note could look like. We want to just say that that's what this visit is for, and then we can say that the patient's asymptomatic or maybe they have some slight low back. If we want to do a pain scale, that's fine as well. We would also want to say that there's no major functional deficits, separating this out from an active treatment note. The documentation guidelines that we have to meet for maintenance and wellness care is going to be your state minimum documentation guidelines and liability considerations, right? We always have standards, but when we're not billing to third party, then this is what we're looking at. What is the patient coming in for? Do they have any symptoms? Are they asymptomatic? Do they have functional deficits? Probably not if they're in maintenance, right? That's one of the keys to maintenance. And the visit number, not so important now because we're not in an active treatment plan. Wellness visit, same thing. Asymptomatic, no functional deficits. It's wellness. They're coming in to get a wellness visit, and we're just going to say that in the note. In the objective section of our routine office visit, that's where we're going to go back to that ART data gathering. So asymmetry, range of motion, tissue tone change. What are we seeing? What are we palpating? What are we observing? And then putting that in our objective section using our chiropractic findings. Again, being as detailed and measured as possible so that we can show progress. So range of motion in degrees is better than range of motion mildly restricted. Soft tissue findings being rated by severity is way better than just they have a muscle spasm. Showing measurements of asymmetry of posture and also showing percentage of impairment or improvement when possible. Not necessarily needing all of these things, but where we can be more detailed so that then future we can show the change. Here's an example, several examples actually, where we could document changes objectively. So left foot flare decreased during preambulation by 10 degrees since last visit. Patient is now 95% of within normal limit. Cervical right lateral flexion has improved 10% since last visit, resulting in an increase in 5 degrees. So, there's measurements there. That's awesome. Then we can really show that throughout the episode. Bilateral trap spasm has decreased from moderate to mild since last visit. Still better than just, I've got a trap spasm. Here is an example in ChiroTouch of objective findings for a daily visit or a routine office visit. And what we see here is that we've got our subluxations listed out, C4, 5, 6, and 7. We've got our pain listed out as mid to lower cervical and upper right arm. We've got our posture analysis. We've got our muscle spasms, 5 out of 10. So we're grading those, which is awesome. Posterior cervical. We've got our range of motion, which is cervical extension flexion, left rotation, right lateral flexion, moderately reduced with pain noted. Perfect. You could even add a detail of where that pain might be noted if there is any specific detail to add there. So here's another example of active treatment note, objective section, and you're just going to see similar language here to what we just looked at. This is in ChiroTouch, and we've got, you know, an excellent way to show our chiropractic findings, meeting all of the requirements for part, knowing that we have to pay attention, that we know we've got to hit those 2 out of the 4 for any region that we're going to want to adjust and bill, you know, as medically necessary areas, obviously supported by our complaints as well in our diagnosis codes. But this is where we can split out in the objective section, we can split out our primary regions of subluxation and our compensatory regions, meaning I've got medical necessity for cervical, lumbar, and sacrum. I don't have medical necessity for thoracic, but I'm going to adjust it because it's important, it's compensatory, it's clinically appropriate for me to adjust it, but I'm not going to count that region when I go to code the CMT, the chiropractic manipulative treatment. When we document our soft tissue findings, that helps support any muscle work that we're going to do as well. Here's the preventative maintenance portion of the objective section of the note. We definitely want to document where the restrictions are to support what we're going to adjust. Same thing with wellness. You know, you want to have findings where you're going to do a treatment. So that's the important piece of those two types of note with the objective section. Our assessment in a routine office visit is super important and becoming more important all the time. This is really where we tie the whole note together. We really can take that S and that O on a day-to-day visit and then make a comment of how the patient's progressing. This is can be a very painful section of the note for us. You know, as a chiropractor, you're thinking this in an instant, but then we have to stop and put it into words, right? And sometimes that can be a little painful. But it's important, even if it's just a little bit extra information, to add in that they're better because of this, and really tying that progress through the whole episode of care, so that if someone was to take all of the notes from the initial to the discharge, looking at each individual routine office visit and the reevals, and just reading the assessment section, they can, from that, glean the patient progress and why the doctor thinks that. The patient's better because they were able to walk further without pain. The patient's worse, they had an aggravation. There's more muscle spasms. I'm going to have them come in an extra visit this week. The patient's the same. Not a lot of progress today, but I expect that to change. We're going to keep going. That's that assessment piece that just kind of ties the whole episode together and shows that patient progress that's so important. So from our P and our ART, we gather our assessment from our subjective and our objective. And that's really just that doctor thinking about how effective is this treatment? Is the patient progressing like I expected them to? Do I need to do something different? All that happens, like I said, in an instant. One consideration for assessment is the patient's own assessment of their condition, right? So what are they telling you compared to what you're seeing? And then being able to, you know, meld those two pieces of information together for an accurate assessment. That is something that we've got a few examples of here. The patient indicates that her pain is unchanged, but upon palpation, there's less spasm in the low back than the previous visit. I believe her condition is improving, right? We've got patients that come in all the time and tell us I'm the same, or I don't know. And so being able to not just only rely on what the patient is telling us, but to rely on our objective findings and making sure that's documented as well will help show those times when maybe there's not a ton of changes, but we're still seeing progress. The patient's opinion that her ability to walk 20 feet without increased pain in her knee is questionable because I observed that she has difficulty walking the 15 to 20 feet from the reception room to the treatment room. She still has room for functional improvement. So this would be like the patients that are coming in and they're like, I'm great, but they're really not. So again, using that doctor thinking to take all those pieces of information together and be able to document it is important. And it's just where that happens is in the assessment section of the daily note. Here's some good language for the assessment of our ART, or our objective findings. The slight improvement, approximately 2 to 3 degrees in her low back range of motion, indicates that her condition is improving. Increased muscle guarding in the cervical spine after the last CMT indicates that the patient is not responding well to diversified adjusting. We're going to change the technique to high velocity, low amplitude thrust for the duration of the treatment plan. So again, really just taking all of your doctor thinking of the information that you have at hand and then creating a good daily assessment of patient progress. Remember, it's all about function. How is the patient improving? Why do they need more care? This really helps establish medical necessity throughout the episode. So here's an example. This is, again, in ChiroTouch for a routine office visit assessment. It says Anne is showing improvement and treatment will continue as ordered in the treatment plan. In order to reach the functional goal of climbing stairs and sleeping without any disturbance. So that's a great one daily visit assessment. Then the next one would maybe say something, different of she's still showing improvement and she's able to climb the stairs without pain for one flight, for example. Just building upon those daily assessments to really capture, again, the whole episode. The preventative maintenance assessment would be pretty straightforward. This is preventative maintenance. We're doing the patient's functional. We're just trying to keep the patient that way. And then we can include our diagnosis codes here on a daily visit. There may not be an initial visit, right, for maintenance. So we would want to include those on the daily if necessary. Our wellness visit assessment would be wellness care for subluxation correction to maintain and improve neurospinal integrity, overall health, and general well-being. So just a nice little statement of this is wellness and we're just trying to keep this patient healthy. That's our doctor thinking for why we're treating the patient for wellness. Our plan section of our routine office visit is where we're going to say what we did to the patient each visit. So what services were performed. We use this section of the note to inform our CPT code selection. So if we say we're adjusting, one region of the spine, that's going to inform our 98940. If we're saying we're doing therapeutic exercises, for 8 minutes, that's going to inform our 97110 1 unit. We want to include details for any services that we're doing. We are adjusting using diversified to C5. We are doing this modality to this region. Here's our settings. Here's our time. When we talk about CMT coding, we'd just like to remind everybody that our spinal regions that we use to count, whether it's 1 region or 5 regions, are cervical, thoracic, lumbar, sacral, and pelvis. Posterior ribs are included with thoracic and coccyx is included with sacral. Our extra spinal regions then, if we were to have complaints and support for billing in 98943, would be head, upper extremity, lower extremity, rib cage for anterior ribs, and then potentially abdomen. Our purpose of the plan for a routine office visit is not the full treatment plan. That's the initial visit purpose of a plan, is the full treatment plan for the episode. This is, what am I doing to the patient today? Again, we're going to include specific segments adjusted. So rather than saying, see objective findings, we need to say, I adjusted C5, T2, L3. we need to say, I did this therapy to this region with these details for this amount of time. And on therapies, really any detail that you can put in there is better than just general details, whether it's setting or the type of therapy you're using. All of that extra detail is super important whenever we're billing. If you're giving the patient anything to take home, you would want to put that in your plan as well. If we have a change to our plan in the middle of our episode and we're not really at a re-eval, but we need to change something, we can absolutely add something, we can take away something, we can change, our therapy parameters. And what we would do then is go back to the assessment and say, I'm changing the treatment plan to include blah, 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 or I'm taking out this therapy because the patient isn't responding as I expected. We're going to see how they do with adjustments only for a few visits. Those kind of changes are going to happen, in the plan. You're going to say what you did to the patient that day, but we're going to talk about it in the assessment, why we're changing what we're doing. Here's an example of the plan section of the note for routine office visit. It falls under today's treatment in ChiroTouch. And you can see we've got our primary treatment with diversified to L4-5. We've got our supportive therapies, our therapeutic exercise with the exercise, the sets and the reps and the time. We've got manual therapy on this one with where we're performing that manual therapy, what kind of manual therapy it is, and then the time for that one as well. When you do timed codes for your therapies, and we've got more than one, we want to put individual time, and then we got to put total time, because that total time is where we're going to get to the correct amount of units from whenever we go to code how many units are happening for those therapies. Okay, so this would be an example of splitting up our primary treatment and our compensatory treatment. So we kind of talked about this a little bit in the objective section. This is really where it needs to happen for coding. So if we have medical necessity for an upper body complaint, C345, T1, T2, those would be our primary treatments. We would have a history about that with complaints. We would have objective findings. We would have our diagnosis codes that would be part of our treatment plan. However, maybe we're a full spine adjuster and we know that it's important to adjust the lower body as well. Those would be what we would call compensatory areas. And it's, again, clinically appropriate to adjust those. We're going to say that we adjusted them. We've got to document what we do to the patient, but we're not going to count those for billing. So the easiest way to split those up for clarity is to call it primary and compensatory. And you absolutely have that capability in your ChiroTouch system to do that. The other modalities here that are listed as examples are hot pack with the time and e-stim unattended with the area and the time, as well as documenting how the patient responded to the treatment and then what's our next steps. So we're going to just keep following the treatment plan as scheduled. Preventative maintenance plan would just be technique, segments adjusted, any home care, and then what's next. Same thing with wellness. Technique, segments adjusted, how they responded, when we want them to come back again. Okay, so this is what the whole note would look like when we put all these pieces together, the subjective, objective assessment, and plan. We've got our daily encounter with our visit numbers. We've got our chief complaint, identifying the area of complaint with our functional change visit to visit. We've got our daily objective findings where we're supporting what we're going to treat. We've got our assessment to document how the patient's progressing based on our subjective and objective findings. And then we've got what we did to the patient today. And of course, all of these would be signed. So just kind of a quick recap of SOAP is subjective is what the patient's telling you. Objective is what you're seeing clinically. Assessment is what your doctor thinking is about what's going on. And then plan is what you're doing about it. A couple of things just to kind of bring to the conversation here is when we're reviewing notes, when we're auditing notes, when we're looking at what different denial comments are from payers, a lot of times what they're saying is that the daily visits are lacking the function related to subjective, the quantified objective findings, and then the written assessment showing how the patient's doing and how they're progressing. And so those are the things that we would want to just, emphasize. Make sure you're doing these things in your note when we're billing medically necessary care. Each visit is a chapter, a page in the story. And, not only does it help us as the provider to recall what's going on when we're seeing lots of patients, right? But it also is a record of making sure that we have all our details documented so that if anything should happen, it's all written down. We don't have to, worry about relying on our memory. We've got it documented and we're good to go. Lastly, the thing that we would just want to say is be careful if you're salting. Salting can be a great tool, but if we're not having the discipline to go in each day and edit the note to be accurate for that encounter, updating all the things that we just talked about, the functional change, the objective findings, our assessment, and any changes to the plan section, then we just really are putting ourselves at risk for if we were to get a record request, because everything will just look the same. And we don't want that. We want to show accurate patient progress visit to visit. So we just want to make sure that we're telling the whole story of our patient's episode. And this section of that episode would be the functional daily notes or the routine office visit. And that is the end of the story.
Oh, that's great. Dr. Colleen, we do have a few questions if you have time.
Sure.
Okay. Let's go back a little bit of ways just to confirm. If a patient has no functional deficits and only pain, say like on a scale of 3 of 10, is that not an active plan or active care?
So the direct answer is no, that's not active care, but there are multiple pieces to consider for active care. And one of the biggest pieces is that functional deficit. So being able to establish what happened, what can the patient now not do that they could do before that thing happened, objective findings to support what we're going to do with the patient, our diagnosis, and then our treatment plan that's got functional goals. That's like a nutshell version of medical necessity and when we can call it active care. If we only have pain and that's our only finding, that is not enough to support medically necessary care.
Okay, next question. Thank you for that. For
Sure.
Therapeutic exercise, do you have to list the actual start and stop time or just document the total minutes?
So we almost always see total minutes. I have seen, and this is where the answer that it has become almost our answer to every question is make sure with your payer policies what they require. I have seen once where they wanted a start time and an end time. Typically, though, it's the total time of the therapy. So the 8 minutes or the 12 minutes or the 20 minutes of each therapy. And then we recommend, like I said, doing the total time of all of the timed therapies for proper coding.
Great. All right. Next question is, can extra spinal be compensatory? For example, TMJ with upper cervical.
It could be. Absolutely. And then my question would be, do you have medical necessity for TMJ, or is it part of the cervical complaint and that's what we're showing in the documentation because that's what we found clinically with the patient? If those two are tied together, we're going to decide clinically Is it the cervical spine and the TMJ is compensatory? Is it the TMJ and the cervical is compensatory? Possibly, do we have two separate complaints? We've got a neck complaint and a separate TMJ complaint. So that could shake out in a lot of different ways, but yes, it could be.
Okay. All right. In the assessment section, updated each visit or just at exams, is it updated just at each visit or just at exams and for re-exams?
So your initial assessment is going to look different than your daily assessment. Is also going to look different than your re-eval assessment. Initially, our assessment is going to be establishing what is the condition that the patient's coming to see you for. What are you identifying that condition to be? So how are we diagnosing it? How do you feel like the patient's going to progress through the recommended treatment? Are there any complicating factors? Are there any contraindications to care? So that's all initial visit. Daily assessment is the little sentence or two of here's how the patient's doing and why I say that. They're better. We're working towards their goals. They're able to walk a little further without pain. Versus re-eval assessment is going to be a bigger story of here's where the patient's at with their complaint. Here's where the patient's at with their functional deficit. Here's where we're at with our goals. Here's an updated outcome assessment score compared to our original one. And here's what I want to do next with this patient. So they're all just a little bit different. But yes, we want to update that assessment daily so that we don't end up with multiple daily notes that all say the same thing. Patient progressing as expected 10 times in a row. That's just not going to get it done anymore. We've got to put more detail into those dailies of why do we say that.
Second part to that question is the prognosis good, fair, or poor required as part of the assessment?
Required, again, I would say find out from your payer if they require it. It's a good idea to have some kind of a statement in there of how you feel like the patient's going to progress with what you want to do with them.
Okay.
If anybody wants to email KMC University just for any kind of a conversation about how we could help you with documentation, coding, compliance, billing, you can email us at info@kmcuniversity.com.
Fantastic. Dr. Colleen, thank you. This presentation was very rich and very much actionable. And as a former front desk person myself, I learned a ton. So thank you for that. We appreciate you spending time with us today. And as a reminder here, if you would like to speak to a chiropractic specialist for 5, 10, 15 minutes to ask a question or talk about your situation, you can scan the QR code and we can get you connected with someone. Thank you for joining and we'll see you next time.
Thank you, Debbie. Bye.